I presented and chaired the Meet the Professor session here at SOHO that focused on various molecular subgroups and how we're approaching them, especially the difficult molecular groups. One of these includes TP53-mutated acute myeloid leukemia. This is probably the most difficult and unmet need population in acute myeloid leukemia today. Even with the new drugs we're having, venetoclax, menin inhibitors, FLT3 inhibitors, IDH inhibitors, the CD123, CD33 ADCs, the one group where we're not able to really currently improve the survival or move the needle has been TP53. One of the things that we focused on is the role of allogeneic stem cell transplant, which is probably the only intervention which has shown some degree of benefit in TP53-mutated AML. And many analyses, including data from Coleman-Lindsley in the Dana-Farber group, as well as our group, as well as Justin Loki in the UK group, have shown that transplant does seem to have some curative outcome in TP53-mutated AML and MDS, with about 25 to 30% patients having a potential for 2 to 3 years survival. So today in our practice, whatever therapy we start with, HMA venetoclax, HMA intensive chemotherapy, our goal is to get the patients into a morphological remission, less than 5% blast, and move to transplant. We do like to achieve MRD negativity. However, this is quite rare in TP53. So if we do not achieve MRD negativity, but there's morphological remission and a donor is available and the patient is in good condition, our preference is to move quickly to transplant because the duration of remission in these patients tends to be quite short. So if one does not move to transplant rapidly, they will often relapse. There are a number of new emerging therapies, mainly in the immunotherapy arena, including off-the-shelf allogeneic CAR T cells, NK cell-based constructs, new bispecific engagers, as well as a whole new group of antibody-drug conjugates that is coming into the field. And so we're hoping that some of these will be mutation agnostic and work in the TP53 field, but at this point we don't really have any clear data or evidence about when and how that will happen. So it's still an area of tremendous research, but just as we have seen with the FLT3 and we have seen with the menin and the KMT2A, both of which were historically very high risk and have been transformed with the emergence of effective targeted therapy, we also hope in the next few years this will be the case and happen for TP53 mutated disease.